So I got into the military to pay for college at the University of Mississippi. And then I got a deferment to go to medical school. I kind of knew I wanted to go into medicine. Wasn't 100% sure when I started college. But as I went through college, I decided I did want to do medicine. And so since I was already kind of on a military track with ROTC, I asked for a deferment to go to med school. They approved it. They then funded me through a HPSP scholarship program. And then what I accumulated with that was 8 years of active duty obligation. And that starts after I finished my training. My training was 7 years after graduating from med school. And so then I owed 8. So that got me to 15 years. And I only needed 20 to retire, so 5 more years. It's been a wonderful opportunity for me. I'm ending my career this year. And so with 20 years on active duty, 13 of those I've been a liver doctor. It's been fantastic. We have a very large fellowship training program, and I've been able to train quite a number of fellows in liver disease. And then interacting with my patients, we have a wonderful patient population. They're very receptive to clinical trials. They're very receptive to following orders and directions as far as when we give them diet and lifestyle recommendations. They tend to do, I think, a better job than the general population. So it's rewarding to see my patients when they first come in versus a year, 2, 3 down the road, because they really take to heart what we tell them as a general rule. And then providing care to our active duty population of soldiers, whether it's fatty liver disease or hepatitis C or Hep B or autoimmune liver disease, or you run the gamut. It's an honor and a privilege to have cared for America's finest. So this is where hepatitis C was 10 years ago. So the world is your oyster here if you're a liver doc that has an interest in NASH, because we don't know enough about the prevalence of disease. Who is really at risk? Who's that 30% that progresses versus the 70% that has fat that they grow old with their fatty liver? What are the characteristics that define that patient that comes into my office? So I can say, you're the one I need to worry about. Yeah, you need to lose weight and exercise because of all the other comorbidities like cardiovascular disease and stroke and that sort of thing, diabetes, but you're not really at risk of a liver-related death. How do we distinguish those people? So we need a lot of work still to do there. And ideally, we need to get there non-invasively. So a lot of work there. A lot of work in imaging, finding that ideal test. Is it a portable FibroScan machine where I can just do an elastography? Is it an MRI-based product? Is it a combination of imaging and blood work and clinical data? Ideally, the easier test to do that's readily available, cheap, has a high sensitivity and specificity, and provides very little harm to the patient, risk to the patient. That's the ideal non-invasive test. We're not there yet. And then, of course, treatment. We need to know what therapies work, what combinations are going to work best, how long we need to treat them. And then natural history. We don't know what this disease means necessarily. If I tell you today you have stage 2 disease, stage 2 NASH, when will you be stage 4? Can we predict how quickly you're going to progress? So a lot of work there as well.